It's my pleasure to introduce Haley Griffin. She is a PharmD and currently a post-grad year 2 geriatrics pharmacy resident at the Minneapolis Veterans Affairs at the healthcare system. She completed her Doctor of Pharmacy degree at the University of Colorado SAG School of Pharmacy and Pharmaceutical Science. That's a mouthful. It needs to come up with an acronym, I think. After obtaining a Bachelor's of Arts degree at the biology of Gustavus Adolphus College in St. Peters, Minnesota. She's also the co-chair of the Federal Resident Committee, which serves all Veterans Affairs pharmacy residents. Her professional interests include deprescribing, which, yes, right? Dementia and heart failure. So give a warm welcome to Haley.
Hi, everyone. Thank you. Oh, let's get this. There we go. That's better at my height. So again, my name is Haley. I'm a current pharmacy resident, and I'm really excited to be here. Being a fairly recent grad, most of my presentations have been virtual, so to get to actually see everybody's faces and have some more interaction, I'm really excited for this. So first, I just want to say I have no financial disclosures, and the contents of this presentation do not reflect the views of the United States government or the views of the Departments of Veterans Affairs. Have to throw that in there. So here is a brief outline of what I will be covering today. I'll go through some learning objectives as well as some background, although I'm sure we all know the background that I'll be going over. I'll go over our current medication treatment options for dementia, as well as deprescribing. After that, we'll walk through a patient case to see how we can go about deprescribing, and then I wanted to highlight a little bit of the medications on the horizon. So first, for our objectives. After this, I want you to be able to interpret the current evidence for medications used in dementia. Second, once you can interpret and evaluate that evidence, I hope that you can evaluate the risks and benefits of medications and their use. I want you to, third, identify potential candidates for deprescribing medications for dementia. I know deprescribing is a newer thing, I guess obviously not with our crew here, but something we don't have a lot of guidance on, so really excited to dive into that a little bit more. And then with that, developing a plan for deprescribing these medications. As I'm sure we're all well aware, and we actually heard a bit about some of these background statistics from Dr. Khan earlier, there are approximately 6.5 million Americans 65 years and older who are living with Alzheimer's disease. Alzheimer's disease is also the 5th leading cause of death in Americans that are 65 years and older. I believe it used to be higher, but I think COVID knocked it down one. And then it is estimated that unpaid caregivers spend 16 billion hours annually providing care for those with Alzheimer's disease in 2021. That value is at over $270 billion. That's not talking about the physical or emotional toll to caregivers, and this isn't including everyone in this room who gets paid to do that. So just to help bring that into a bit more context. So first, I'll outline our current medications that I'm sure we're all well aware of, but maybe just, give us a little refresher. So there aren't too many FDA-approved medication options for the treatment of Alzheimer's disease. So as we know, dementia has many different types. For this presentation, I'm specifically focusing on Alzheimer's disease because that's where the majority of the medications have approvals for. So first, we have our cholinesterase inhibitors. So they essentially help block that breakdown of acetylcholine, hoping to enhance those cholinergic connections. And those medications are donepezil, galantamine, and rivastigmine. Next, we have our NMDA receptor antagonist, which is memantine. And then finally, more recently, there is the anti-amyloid monoclonal antibody. I know if you were here last year, the pharmacy presentation was on this medication, and it is aducanumab. I do have an asterisk next to it because there are a lot of significant risks associated with the use of aducanumab. Therefore, most patients are not going to pay for this out of pocket. CMS and the VA will only cover for patients who are participating in clinical trials. And I don't believe there are any current clinical trials currently going on in Minnesota. Therefore, I'm not going to talk about it anymore in this presentation because I don't think that it is relevant to us. All right, so now to dive a little bit deeper, and I will encourage some participation, or you can just think about the answers in your head if you don't want to shout them out. So which medications are currently FDA approved for mild to moderate Alzheimer's disease? Is it donepezil, galantamine, rivastigmine, memantine, all of the above, or A, B, and C? All right, we got it, A, B, and C. So just a quick refresher of what these medications are specifically FDA approved for. So donepezil is FDA approved for mild, moderate, or severe Alzheimer's disease, so it can be used in all stages. Galantamine is only FDA approved for that mild to moderate Alzheimer's disease. Rivastigmine is approved for mild to moderate or severe Alzheimer's disease. It also has an additional indication for for dementia associated with Parkinson's disease, and that's specifically for the rivastigmine patch. And then we have memantine, which is only approved for moderate to severe Alzheimer's disease, and I'll touch on that a bit later in this presentation. So now I want to talk about what is our evidence for benefits. So I'm using this fairly recently published review article in Internal Medicine, and it's the benefits and harms of prescription drugs and supplements for treatment of clinical Alzheimer's type dementia. So this is a systemic review and meta-analysis, so I'm just going to highlight some of the key points from this. So first, we want to know what is the actual evidence for benefit. What was found in the trials? Why do we use these medications? So first, the cholinesterase inhibitors, and I'm just kind of grouping them all together here. So they were favored over placebo on tests of cognition, on function, and on that global clinical impression. So that's where they were favored. However, it's a very low strength of evidence, and that's because they only found small average benefits for that mean change in those cognitive test scores. So there might be some benefit, but it was small. And then there was no difference to a small benefit for that mean change in function. So overall, yes, they're favored over placebo, but the evidence doesn't show to a high degree. It's maybe a mild benefit. Next, we have memantine, which is the NMDA receptor antagonist. So it actually did not demonstrate any benefit on cognition or function compared to placebo in that mild to moderate Alzheimer's disease. That is why it is not approved for use in mild to moderate Alzheimer's disease, because if there's no proof that it's going to work, we're not going to put someone on it. There was a small benefit in that global clinical impression when it was added to a cholinesterase inhibitor in that moderate to severe Alzheimer's disease. But it is approved for both use by itself or in combination with a cholinesterase inhibitor. So now I'm hoping I can get everyone to contribute some to this conversation. So in your practice, how would you monitor for benefit, or how do you monitor for benefit? Or are you scratching your head saying, you know, I don't actually look to make sure that they are getting benefit with these medications? So if anybody would like to share. All right, I'll start over here.
I'm always interested to know if they are remembering how to use their telephone to call family.
Oh, that's great. So just so that people can hear if they're watching online later, watching to see, you know, can they still remember how to use their telephone to call their family? I like that.
I try taking them off and see if there's any change.
Yes, so we will get to that. That is also one way. So the response was, I tried to take them off the medication and see if we notice any difference. All right.
If their mood is stable, mood stability.
Okay, yeah, so suggesting seeing if there are more mood stabilization. Is that improving? And then I'll do one more.
Talking to family about the perceived benefits.
Yeah, so talking.
Later on, after they've maybe been on it for years.
Mhm.
So,
Yeah, so talking to the family, do you think they're doing better? So here's actually, that's the perfect segue into what I'm going to. How can a family member tell if someone is improving, you know, especially if they're home and not, you know, in a facility, or even for those in care facilities? So we need to be able to communicate that possible benefit before prescribing and during it if someone is taking these medications. First and foremost, it needs to be highlighted that these medications will not reverse the disease or slow disease progression. It simply provides some mild symptomatic benefit. So the best way is, it wants to be very patient-specific. So maybe ask the patients or their caregivers, what were the first things you noticed changing when they got diagnosed with Alzheimer's disease? What was going on? Did they have problems with word finding? Well, then look to see if that starts to improve. A big thing is being involved in conversations, or forgetting they had conversations, or maybe not being able to follow that conversation. So seeing if they're being able to catch on more, staying more engaged. So this should be highly patient-specific, but look for where those biggest deficits were and then see if these medications help improve upon that. One thing I hear caregivers, loved ones say a lot is when they start these medications, they're more like themselves again. And that's one of the best things you can hear. Now with the benefits, as a pharmacist, I always have to talk about the risks. So that's what I'll be moving towards. So first, for the cholinesterase inhibitors, as a medication class, they all have pretty similar side effects. So the first one I want to highlight is bradycardia, which is that slowed heart rate, that slowed pulse. So that's something you always, try to monitor those vitals, see, if they have a low heart rate before starting one of these medications, keep an extra eye on that. As a pharmacist, I always look for other medications that could be causing that bradycardia. So the biggest one that comes to the top of my head are those beta blockers. So if someone is already on a beta blocker, seeing where their heart rate is, seeing if they need to still be on that beta blocker, because that's a potential medication you could deprescribe. The next most common side effect are those GI or gastrointestinal effects. I hear a lot of nausea, vomiting, and also diarrhea with these medications. So just keep an eye on that. If someone already has that, maybe slow down a bit before starting the medication. But those are the things you want to watch for. And then in their systemic review, they did find that there was a higher risk of discontinuing treatment due to adverse effects for donepezil and rivastigmine versus placebo. So essentially saying those in the studies discontinued those more than placebo. Galantamine is not included because there was just simply not enough evidence to be able to include galantamine in this. And then for memantine, I will say it's overall generally well tolerated. There's been some reports of dizziness or confusion. However, there was no difference in withdrawing the medication versus the placebo due to adverse effects in different trials. And now I want to look a bit more into the serious adverse effects. So this was a study published earlier this year in Drugs and Aging, and they looked at the risk of serious adverse events associated with the individual cholinesterase inhibitors used in older adults with dementia, and this was a population-based cohort study. So this was a retrospective cohort study, and it used Medicare claims data from 2013 to 2015. The objective of the study was to evaluate the risk of serious adverse events associated with the individual cholinesterase inhibitors in older adults with dementia. So they classified these serious adverse events as emergency department visits, inpatient hospitalizations, or death. Patients were included if they were 65 years or older, they needed to have a diagnosis of dementia, and if they had any new prescription for cholinesterase inhibitors, and they needed to be continuously eligible for Medicare at least 6 months before that prescription date. That's so they could ensure they didn't have a previous fill of cholinesterase inhibitors, at least in that 6 months before the index date. And then through the end of the study, which was 180 days, and this was a time to event analysis, patients were only excluded if they had Parkinson's disease or Lewy body dementia or a prescription for anti-Parkinson's medications. I believe that is because, as we discussed earlier, rivastigmine has its own separate indication for Parkinson's dementia, and we wanted to focus just on that Alzheimer's disease, so it could be a more homogeneous study group. So I realized you do not have the full study population on here, but it was over 700,000 people ended up being included because this was Medicare data. It was a huge pool. And this is just those crude results. And so looking at the different cholinesterase inhibitors and the percentage of events, the top row was those serious adverse events, and they look pretty similar across the board initially. They're all in that 15% range. And that when you look down all of them, the ED visits, the hospitalizations, the death, the rate of serious adverse events, when you just look at that crude numbers, they look pretty similar. I did want to highlight that this does not include a control group, so this is everyone on cholinesterase inhibitors, so we don't have something to compare it to. And these are just observational results to estimate whether or not there are differences. But they were actually able to do some further secondary analysis to try to rule out some possible confounding variables, such as comorbid conditions, other medications, and things like that. And when they went through multiple steps of data analysis that is above my level of understanding data analysis, they were able to find that both rivastigmine and galantamine had a higher risk of serious adverse events compared to donepezil. So again, we're not able to compare this to the general population, but just something to keep in mind that we do have those risks. And if you are going to start a medication, I know we generally start donepezil as first line, and this could be even, more evidence to suggest that donepezil would be that first line option. But now that we have talked about the benefits and the risks, we want to talk about deprescribing and how to approach deprescribing. So I'm sure you're all aware of this definition, but deprescribing.org describes deprescribing as the planned and supervised process of dose reduction or stopping of medication that might be causing harm or no longer be of benefit. So as we know, there's very little guidance on deprescribing. Fortunately, there is a guideline summary published in 2019 about how to deprescribe cholinesterase inhibitors and memantine. So again, a guideline summary, tools that we can use. They highlight 3 specific times where you could consider deprescribing these medications for dementia. The first time being if you're noting a significant worsening of cognition or function over the past 6 months. At that point, the medication may no longer be providing any benefit because remember, the studies showed only that mild amount of benefit and not everyone will experience it. If someone had been taking these medications for around a year and there's been no noted benefit, then you could consider deprescribing because maybe they're not responding to it, and let's just help mitigate any risks of potential medication interactions or side effects. Finally, severe or end-stage dementia. So when that goals of care may be changing, that's another time you could consider deprescribing. I've heard clinically in practice that some providers like to use that transition to a nursing home. Could be one of those times where they no longer can care for themselves at home or have enough of that, so maybe the medications aren't going to be helping at that point. So now, okay, we want to deprescribe. How are we going to do it? So you can always call on your pharmacist, but just a general rule of thumb that this guideline summary has is that you want to taper the dose about by half every 4 weeks until you are at the lowest available dose. That's to help prevent any potential withdrawal events and also to see, if anything is changing. And they suggest to monitor each medication based off of half-life. So I put up a table with the different half-lives of the different medication used for dementia. So a rule of thumb in pharmacy is that a medication takes about 5 half-lives to reach that steady state in the system, and then it takes about another 5 half-lives from stopping the medication for it to be cleared out of your system. So when you look and you see that both donepezil and memantine have very long half-lives, so in my mind, if you stop it or miss a dose, you're less likely to notice, any serious withdrawal event or anything because you're still going to have a lot of that medication in your system. Whereas if you look at that galantamine or rivastigmine, anywhere from that 1.5 to 7 hours, you're going to notice those changes more quickly. So it's just to keep in mind, when do I need to check back in on my patients if we're stopping these medications? When are they likely to see any of those effects? So it's recommended to trial that discontinuation to taper and monitor for changes. So I took this table and I kind of reformatted it from this review, and I thought it was extremely helpful of what to look at when you're deprescribing. And so it's looking at symptoms based on the timing. So if you're decided to start tapering a medication or stopping it and you're within that first week of making that medication change, if you start to notice severe agitation, aggression, hallucinations, or reduced consciousness, that could be an adverse drug withdrawal event. So in that case, they could be going through withdrawal. The most appropriate thing to do would be to get them back on that previous dose that they were on or back up to the top dose and see if the symptoms are resolved. So now let's say, they stop the medication and you're noticing some worsening cognition, some worsening behaviors, some worsening psychological symptoms, or their function is going down. Now that depends on what is the timing. If you see that within 2 to 6 weeks of stopping the medication, it's likely the reemergence of those symptoms that were being treated by the cholinesterase inhibitor or memantine. So as mentioned before, if you stop it and pretty soon you're noticing those changes, well, they probably were getting benefit, time to go back to what dose they were on. If you're noticing at that 6 weeks to 3 months mark, that can be a really challenging time to decipher if it is that progression of underlying disease or if it is that reemergence of symptoms that were being controlled. So that's more of the gray area. We'll need to have, those risks versus benefits conversations with the caregiver, with the patient, and see what to do at that point. If it's over 3 months since you've discontinued the medications, it's likely just the progression of the disease. So to help illustrate this and, starting these medications, when to consider stopping, I do have a patient case that I would like to go through. And I will have lots of questions in here, so feel free to shout out answers. So some background. This was a 71-year-old male patient. They have a past medical history of type 2 diabetes, coronary artery disease. They had a triple bypass in 2011. They have PTSD, restless leg syndrome, possible REM behavior disorder, past alcohol abuse, GERD, hypertension, and they were diagnosed with Alzheimer's disease about 6 months ago. So now, initially, they were noted in that cognitive decline for about 1.5 years before the diagnosis. They had the diagnosis and wanted to wait 6 months before starting anything. Patient-reported symptoms, the patient said they were having that difficulty remembering conversations, some difficulty with word finding. So potential targets of things to watch for improvement if you want to start these medications. The caregiver had some more specific examples, such as the patient was forgetting how to play cards, they were misplacing items, and quicker to anger. So now we're about 2 years since the diagnosis, and the caregiver was asking about starting a medication due to that worsening confusion. So now I have a med list. So you can see here we have amlodipine, likely for the heart, aspirin for his heart, atorvastatin, goes back to the heart, isosorbide mononitrate, metoprolol, nitroglycerin, all for the heart, pramipexole for restless leg syndrome, metformin, omeprazole, and then loperamide as needed for diarrhea. And they're reporting that the patient is taking the loperamide about once a week. So now, which of these medications could potentially interact with a cholinesterase inhibitor? Could it be amlodipine, metoprolol, metformin, loperamide, all of the above, or specifically B and D? Yeah, that's usually why there's the specific question. So I picked B and D for this response. So as we talked about before, metoprolol, it's a beta blocker. It can cause bradycardia. Donepezil can also cause that bradycardia or the cholinesterase inhibitors, so we want to make sure that you're not getting double that effect. Also, loperamide is an anticholinergic medication, so when you think about our cholinesterase inhibitors and we're trying to promote those cholinergic connections, and you take it with a medication that's trying to stop those cholinergic connections, you're just going to cancel it out. So if they're only taking it once a week, it's likely not as big of a deal, but as I'm sure we are all aware, we want to try to avoid anticholinergic medications in our patient population anyways. I did want to highlight that metformin can cause diarrhea, and so can donepezil. So things just to monitor for, but I think it's a little bit less of a concern than that bradycardia or the loperamide. So continuing on in the case, so this patient actually did have a history of bradycardia. So the provider consulted with their pharmacist. They were able to provide a taper schedule and discontinue that metoprolol. For beta blockers, you do want to taper them off. If you stop them too quickly, you can give them rebound tachycardia, hypertension. I've heard of patients going to the emergency room after stopping it too quickly because they feel panicky and don't know what's happening. So at this point, it was determined that the patient was going to start donepezil, so they started taking 5 milligrams daily for 6 weeks. If they were tolerating it just fine, they could go up to the 10 milligrams daily. 6 months later, another PCP visit, their caregiver was reporting there was no change in the cognitive symptoms since starting the donepezil, and maybe noticing some non-bothersome hallucinations. So starting to question, is this medication working? Is this medication causing hallucinations? Are hallucinations just the next part of the course of disease? Not sure what's going on. 4 months after that PCP visit, the patient actually moves to assisted living and changes cares to the on-site provider. There was worsening anger and aggression noted by staff. So now, taking a step back, what factors make this patient a potential candidate for deprescribing? Is it that lack of perceived benefit after about a year of use? Is it the significant worsening of disease? Is it those changes in goals of care? Or is it, maybe a combination? And I will say, I think you can make a good case for all three. I think moving to that nursing home, we don't know if they specifically had a change in the goals of cares, just a change in setting. But if it was a change in goals of cares, absolutely, that would be a reason. But yeah, so not sure if they're having benefit, if they're having worsening symptoms. Is this medication doing anything? Was it providing those hallucinations? What's going on? So now, how would you deprescribe donepezil in this patient? Would you stop donepezil without a taper? Would you reduce the donepezil to 5 milligrams daily for 4 weeks and then stop? Or would you just continue, not worry about deprescribing, see if the anger and aggression resolve on its own? Yeah, again, trying to be, not thinking too hard here. Based off of the guideline summary earlier, you'd want to reduce that donepezil for 4 weeks and then stop. So per the guidance summary, yeah.
You were talking about going to lowest available dose. Would you go even further with donepezil out of concern for side effects to half of that 5 milligram tablet?
I think you could if there was something that was really alarming, but I don't think it's necessary. Yeah.
And like in every other type taper is kind of common in practice,
Okay.
but not necessarily in the literature. Have you ever seen that?
I specifically haven't for donepezil, but I've seen it for plenty of other things. And you're right, there's such a lack of guidance in the literature that you kind of just see what makes sense with what you have available. And then, again, with donepezil, it has such a long half-life that it's probably just fine. I will say that actually in this patient, they did just stop the donepezil without the taper because there was concerns that could have those hallucinations been a side effect of the medication. And again, it has such a long half-life that I'm not as concerned about, any type of withdrawal or different things like that. And there was some conversation that the caregivers were concerned that they were having side effects. So now about 1 week after discontinuation, the patient was more confused and now experiencing more hallucinations. What's your plan? Are you going to restart the donepezil? They could be having withdrawal. Are you going to restart the donepezil? They were probably getting some benefit. Continue with the trial discontinuation. This is expected to happen. Or start a new cholinesterase inhibitor. I think 2 answers could be reasonable for this one, so this one's a little bit trickier. So I did pick A if we're going off of that guideline summary. It happened within a week. That could be potential withdrawal. I also think that it could simply be that reemergence of symptoms, and so they were experiencing some benefit from that donepezil. Again, that long half-life, it's really hard for me to think that they cleared the medication that quickly to be getting withdrawal. But they could have been having some benefit. So in conclusion, the patient restarted donepezil. They did re-titrate up. They started at 5 milligrams daily for 2 weeks and then took 10 milligrams indefinitely. The reduced taper was just to get back to that target dose. They had only been off of it for a week and they had been tolerating it as far as their heart rate and GI effects. So there was less concern about overdoing it too quickly because in general you do want to titrate up. Anytime you stop the medication, you will have to restart from the lowest dose. So it was reasonable to do that. The patient did return to the baseline level of confusion from starting the discontinuation, and the hallucinations went away. And now this is about 2 years later, and the patient is still on donepezil 10 milligrams daily. So this is a case where, trial deprescribing, it didn't quite go. They went back on the medication, but I thought it did a really good job of outlining, those different medication interactions and how you would go about this. But now I want to talk about when patients can be successfully deprescribed and what is that impact. So there's a fairly recent article in Alzheimer's Dementia in 2020 that I thought would be relevant to this audience, and it was the impact of deprescribing the acetylcholinesterase inhibitors on aggressive behaviors in antipsychotic prescribing, and this is specifically in nursing home patients. So this study, the objective was to evaluate the impact of deprescribing the cholinesterase inhibitors on the aggressive behaviors and incident antipsychotic prescribing in a large sample of nursing home residents with severe dementia. And this was designed as a retrospective cohort study. It was using Medicare claims data as well as the minimum data set, or the MDS, for the nursing home residents. So for the methods, they actually had two different cohort subsamples. So they had the aggressive behaviors sample and the incident antipsychotic use subsample, and that's because there was some slightly different exclusion criteria between the groups. So patients were included if they were a nursing home resident, 65 years or older. They needed that continuous enrollment in Medicare, Parts A, B, and D. They needed to have a diagnosis of severe dementia, and they needed to be receiving acetylcholinesterase inhibitors at that index date, at that study start date. Patients were excluded from the aggressive behavior sample if they had one or less than two MDS assessments. That's simply because we needed something to compare it to. So if they only had one at baseline, we can't compare how those behaviors changed. Second, there was the incident antipsychotic subsample. And so they were excluded if they had an antipsychotic medication supply within 180 days prior to trial start date, because we wanted to see those new starts for antipsychotic medications. So now I took their results table and then tried to summarize it in an easier to read fashion on the side. So they have their two subsamples, the aggressive behaviors, and then a few down that incident antipsychotics prescribing. They have an unadjusted number and then their adjusted results, and that's simply because this was such a large Medicare claims data that it's hard to try to adjust for those confounding variables, so that's why they went to the adjustment. So when you look at the aggressive behavior sample, it included 81,832 patients, and there was no significant difference in behaviors in patients that had deprescribing of their cholinesterase inhibitors. So I know one thing we're always concerned about is, could they be having behaviors if we stop these medications? And in this study, they did not find that. Even more interestingly, in the incident antipsychotic sample, which included 80,033 patients, they found that patients with deprescribing were actually less likely to be prescribed an incident antipsychotic, which again is something we would be concerned about. So this could be, a bit reassuring that we could stop these medications, and as long as they get through that trial discontinuation, that tapering off, that it actually could be beneficial down the road. I did want to highlight that, again, this is observational data, so it is possible that patients that underwent that deprescribing already had less behaviors, so that could skew the results a bit. And they also highlighted that they had a low baseline behavior score, so this was not a highly aggressive or behavioral subset of patients. But I think, something to support that if you do want to go through with this, there can be benefit with that. And now just to really hammer in this study. So for this study in nursing home residents, what was the impact of deprescribing acetylcholinesterase inhibitors on that antipsychotic use? So those with deprescribing, were they more likely to be prescribed those antipsychotics? Were they less likely to be prescribed those antipsychotics? And where there's no difference in being prescribed antipsychotics? I'm hearing some B. So yes, they were less likely to be prescribed antipsychotics. So that concludes the deprescribing part. I did want to highlight some medications on the horizon just because this is the pharmacotherapy update. So I took this figure from, it was published in 2022 about our current Alzheimer's medications. There are currently 31 agents in phase 3 trials, which is great. 68% of those are disease-modifying therapies. The other ones are either for neuropsych symptoms or target cognitive enhancers. So of the 68%, so 21 in those phase 3 studies that are those disease-modifying therapies, they target 9 different mechanisms. So we're starting to see some are targeting amyloid, some are targeting tau protein. So we're starting to get a lot of these new medications targeting different areas in the pipeline. And then, did anybody get bombarded with news alerts about a month ago about this new Alzheimer's medication that was potentially coming out? Like, raise your hand if you saw the news, had people texting you. Okay, same. So I wanted to discuss a little bit what I could find about this new medication because I thought this could be applicable to us, because I'm sure if you're not seeing it in practice, your family members are texting you about it. So the new medication that is not yet out, but that did a news blast about a month ago, was lecanemab. It is a humanized monoclonal antibody. It's designed to selectively bind and neutralize and eliminate the amyloid beta aggregates, and it's currently being studied in the Clarity AD trial, which is that phase 3 trial. So I went on to clinicaltrials.gov to find out what is this Clarity AD trial. So this was a placebo-controlled, double-blind, parallel group, 18-month study with an open-label extension. The aim is to confirm the safety and efficacy of lecanemab in patients with early Alzheimer's disease. The treatment was lecanemab 10 milligrams per kilogram biweekly as an IV infusion. And then the primary outcome was that change from baseline in the CDR-SB, so that's just a measure of cognition score, at 18 months. So if you got bombarded, a month ago, I just want to highlight there have been no results posted yet. Nothing has been peer-reviewed yet, but what they reported is that the Clarity AD trial met the primary endpoint and all key secondary endpoints. So hopefully this gives you a little bit more, if people ask you about it, that you can maybe answer those questions, but realizing we still don't have any results or anything that's peer-reviewed with this new medication. So finally, some key takeaways is that we do have FDA-approved medications for dementia. They only have evidence for mild symptomatic benefit, and not everyone is going to experience those benefits. There are risks associated with the use of cholinesterase inhibitors, such as medication interactions, some more bradycardia, mild GI effects, but as well potential serious adverse events. One to look into deprescribing, so that could be if there was a noted lack of benefit, significant worsening of symptoms, or end-stage Alzheimer's disease, and then that deprescribing should be closely monitored. All right, here are my references. It looks like we have about 5 minutes until the break, so I'm happy to take any questions. Yeah.
Case I had recently, I had a gentleman in, he had recently moved from the home to a memory care unit in assisted living, and he had been in the hospital and had some care transitions, so his dimethyl was stopped, and his daughter was really upset about that, so wanted it restarted, and he'd had kind of a history of inappropriate sexual behaviors, and those were escalating. And it was interesting because I didn't know this. I think there's a study, and I would be curious to you if you know, that the dinesipil can be activate and contribute to the worsening sexual behavior. So they ended up stopping that, and that was one of the interventions to help.
Interesting. I would need to look into that. I mean, I think it could be possible. I feel like I see Dr. Holman. I know he's presenting on behaviors and dementia after this, so he might know the answer to that.
Well, I may have an idea. And I think that this class of medicines, while they're commonly considered cognitive therapies, they're really neuropsychiatric treatments. That's what they are. And we're going to talk about that. I'm glad that we're back to back here because it's very good. But what they predominantly do is they treat apathy. So they activate patients, which may be why you're seeing higher prescribed rates of antipsychotics in patients in long-term care on these therapies. So that may be part of it. And we'll talk a little bit about how to manage all of this in a behavioral context. But yes, I'm glad that we're together.
I was like, you have the perfect, so I don't have that answer, but that's a great thing to point out, and it's a great thing to look at, a great clinical pearl. Any other questions? Yeah.
I just have a question about a dose question. I think looking at, just up to date, which I look at a lot for prescribing things, I think I've come across that the Canadian labeling for donepezil recommends a maximum of 5 milligrams for women who are over 80 or some certain age or weight criteria. And I don't know if you're
So
familiar
weight
with that,
criteria.
or if there's
You're under 60 kilos, no more than 5 mg, and that's men and women, but women particularly because
Yeah.
of it can prolongate out your QTs, so.
okay, so it's mainly based on the QT?
No, I think it's based on some of the side effect profile that she mentioned.
Yeah,
you know,
I was curious if
nausea,
anyone
vomiting,
has
diarrhea,
seen.
all the cholinergic side effects.
I just see people come in a lot who are on that higher dose who maybe meet the criteria for the lower dose. I don't know if that's,
I see it, yeah.
something we should highlight and learn about. I was curious about others' experience with that.
All right, I see one more question back here.
I've discontinued Aricept abruptly for, I hate to say, 30 years, and I've never seen what I call a,
Withdrawal
adverse
event?
side effects. But the other thing in your case study, when the patient came back to primary care at 6 months, there was no benefit from the drug. It should have been stopped at that time. And if there was, so then, what would be your answer to what would have happened 4 months later? When it was stopped and you had potential adverse side effects?
Yeah, that's hard to know if what was going on. So I think there's a lot of gray area in all of this. And you're right, I wouldn't expect to see withdrawals when I know that the half-life is that long. So one would think you could stop it cold turkey, but it's hard to say. You're right, there's a lot of gray area. I'm not sure.
The other thing is, when Aricept first came out, the drug company provided a diary. And I would have the caregiver, it was a week, week 1, week 2, they had a whole list of things. And so at the end of 6 weeks, I'd have the patient come back and we would review the diary, which was somewhat objective, and then the subjective feelings of the caregiver. And if it wasn't helpful, we would either stop the drug or we would increase it to 10 and redo it in 6 weeks. One of the things that we do not do in long-term care is evaluate any treatment that we provide, whether it's an antihypertensive or an antipsychotic, let's say in 4 weeks to determine if there's a benefit.
Okay.
Yes, take that into account. I mean, the data sets that we do in nursing homes, because I certainly look at those. Like they're using a band.
The MZS doesn't take anything like that into account.
That's interesting. Any?
A lot of nursing homes have MED committees that review all these medications and report back to the prescribers.
And the prescribers.
I would say the providers, the pharmacy, they're really good about following up and making sure if they start something that they're watching for that efficacy and tolerability.
I don't have that much experience in nursing homes. I will say in the clinic that I work at in the VA for dementia, we're utilizing us pharmacists and pharmacy residents to help do that follow-up to make sure that they are noticing that benefit, or if they're having side effects, how we can mitigate that. So I think it's an opportunity. If it's not being done, definitely an opportunity to start doing that.
So may I ask what you're evaluating? Are you evaluating function or behavior or just pure side effects?
Yeah, so it essentially goes back to the slides where I was talking about how do you monitor for benefit. So I asked them, what were those symptoms that they were having? Are you noticing improvement in that? How are things going? I asked specifically, are you feeling more dizzy? Are you having falls because they may not be checking their pulse or heart rate? That could be challenging for someone, especially with dementia. They don't want to get touched. They don't want someone to check that. And I asked just point blank, are you having diarrhea? Like, what has changed? And so I think having that close follow-up is really helpful to see if they're benefiting or not. And I've had people not sure if they're getting benefit, and then down the road, they actually were like, all of a sudden something switched. And I've had people right away say that, the patient was more like themselves, so. All right, if there are no other questions, we're at that 10:45 mark, so I guess we can go into the break. Thank you.